Hello and welcome back to part 6 of the series of videos on pharmacotherapy of congestive heart failure. We've so far seen what is congestive heart failure, and amongst the 3 Ds used for management of congestive heart failure, we have seen the actions, effects and precautions while using the first 2 Ds, that is digoxin and the dilator AC inhibitors. Let's go on to seeing the third D, that is diuretics. Diuretics help this patient of congestive heart failure by reducing the blood volume and thereby reducing the preload. So reduction in preload can reduce the end diastolic volume and thereby reduce the cardiac work and oxygen requirement. The diuretic preferred for chronic management is thiazide diuretics like hydrochlorothiazide because they are moderately effective. Moderate efficacy is a beneficial effect here because in the long run, the chances of electrolyte imbalance are less, and this moderate effect is sufficient for maintenance in chronic management. Furosemide, the more aggressive or more effective diuretic, is reserved for acute aLVF. Before going on to seeing what is special about furosemide, apart from being a stronger diuretic, which helps in acute aLVF situation, let us see the difference between congestive heart failure patient who is ambulatory and a patient who has worsened into acute aLVF, which is a medical emergency. So basic problem in these patients is reduced force of contraction, which compromises the ejection fraction, which is the parameter used to assess the severity. If the ejection fraction is well maintained, these patients are ambulatory, going about their daily routine within their limited capacity. If they overexert, they would become breathless. But a situation of acute aLVF is where even at rest, the patient is breathless. There is labored breathing, and if we do nothing, patient can recognize that he is developing cyanosis. Nails may start becoming blue because gaseous exchange is being severely hampered. There is severe pulmonary congestion hampering gaseous exchange because lungs are filled with fluid instead of allowing air to come in for gaseous exchange and oxygenation of blood. How does furosemide help in this situation? Furosemide, as I said, is a stronger diuretic. But apart from that, even before the diuretic action, it manifests as vascular effects. It has direct vasodilator action, which is seen within 15 minutes, 15 minutes of oral furosemide. The diuretic action onset is 20 minutes. It starts in 20 minutes after oral administration of furosemide, and the vascular effect onset is within 15 minutes. This vasodilatation would reduce the preload and afterload, so cardiac workload is being reduced. Not only that, the vasodilator effect is more in systemic circulation as compared to pulmonary. And as fluid would follow the path of least resistance, this relatively more vasodilatation in the systemic circulation shifts fluid from lungs into systemic circulation. And this shift of fluid from lungs causing pulmonary congestion into the systemic circulation dramatically relieves the pulmonary congestion, dramatically relieves the respiratory distress. So this patient who was otherwise ambulatory, when he goes into acute aLVF for whatever reason and becomes breathless even at rest, do you think he has recognized that his condition is becoming worse? Obviously. And how does it help him to know that his condition is becoming worse? His condition is becoming critical. It obviously doesn't help because this awareness would lead to anxiety. And anxiety, is it good for this patient? Obviously not, because anxiety can trigger sympathetic overactivity. So sympathetic overactivity does not occur only on physical exertion, even on emotional stress. And this anxiety experienced by the patient is going to trigger further sympathetic overactivity, which is going to make the patient more and more symptomatic, more and more worse, because sympathetic overactivity makes things worse for this heart, as we've already seen. If giving a tablet reduces this pulmonary congestion, reduces the respiratory distress, which can be perceived by the patient himself or herself, That also would contribute by reducing the patient's anxiety. And reduced patient's anxiety would reduce the exaggerated sympathetic tone. A milder episode of acute aLVF may be completely aborted by even oral furosemide. If the situation is too bad, if the ejection fraction is too compromised, patient would require ICU care. But with furosemide reducing the symptoms, indirectly reducing the anxiety and reducing the sympathetic overactivity, stabilizes the patient, and we have a more stable patient to take to the ICU. This important role of furosemide in pre-hospital care of acute aLVF must be remembered. Let's go on to see the role of beta blockers in CHF. And before seeing that, let us see what is the role of, or revise, what is the role of sympathetic overactivity. We just discussed that sympathetic overactivity, sudden sympathetic overactivity, can make things suddenly worse by increasing heart rate as well as increasing peripheral resistance and venous tone. So preload and afterload are also being increased. But the important culprit leading to exacerbation of the situation because of sudden sympathetic overactivity is the tachycardia, increase in heart rate. And so beta blockers can help avoid this sudden exacerbation. So sudden increase in workload because of tachycardia and vasoconstriction can push a patient who is ambulatory into acute aLVF and ICU care. And as I said, the important culprit is tachycardia. Sustained overactivity, sympathetic overactivity, can create problems by sustained increase in workload, both preload, afterload, and tachycardia, and progressive damage to the myocardium by increasing the rate of apoptosis of cardiomyocytes. What is apoptosis? The programmed cell death. So sustained sympathetic overactivity can increase the rate of death of cardiac muscle cells. This is going to make the heart even weaker and results in progression of the disease. Sympathetic overactivity also contributes to other features of remodeling, and thus sympathetic overactivity can contribute significantly to progression of the disease. And thereby, we get the role of beta blockers. So beta blockers can prevent the sudden exacerbation into acute aLVF by controlling tachycardia in spite of sudden sympathetic overactivity, which might well be triggered by even emotional stress or physical exertion. Beta blockers can also prevent the adverse effects of sustained sympathetic overactivity, and thereby they reduce the disease progression. So beta blockers are also called as disease modifying agents in congestive heart failure. But, and this important but must be recognized, beta blockers can be used only in patients with well-maintained ejection fraction. So choice of patients for giving beta blockers has to be very careful. Patients with severely reduced ejection fraction, even a little bit of blockade of beta receptors can further compromise the force of contraction. And our purpose here is not to further reduce the force of contraction. So even the dose of beta blocker has to be very carefully adjusted so that it does not further reduce the force of contraction. It does not further compromise the ejection fraction. So carefully selected patients with well-maintained ejection fraction and careful adjustment of dose so that it will only prevent tachycardia in spite of sympathetic overactivity but not further compromise the force of contraction. These are essentials if we want to think of using beta blockers in congestive heart failure patients. Earlier, before this role of sympathetic overactivity and therefore beta blockers was realized, beta blockers were considered absolutely contraindicated in patients of congestive heart failure. So only by using these two strategies of choice of patients and careful adjustment of dose, we can use beta blockers in management of congestive heart failure to prevent sudden exacerbation and prevent the chronic adverse influence. The drugs preferred today are carvedilol, which is not just a beta blocker. It is an alpha and beta blocker. What's the advantage of having this additional alpha blocking activity? Beta blockade would prevent tachycardia, and alpha blockade can dilate the vessels, both veins as well as arterioles, so preload and afterload are also reduced. Plus, it has antioxidant activity, and oxidative stress is implicated in all chronic situations, so this would also be helpful. Another drug which could be used is acebutolol, which has, in addition to beta-1 blockade, intrinsic sympathomimetic activity. So it is less likely to compromise the force of contraction further. But currently preferred drug is carvedilol, alpha and beta blocker with antioxidant activity. That brings us to morphine in acute aLVF. Morphine is a very effective analgesic agent, but these patients in acute aLVF are not complaining of any pain. Then why morphine? Because morphine has a place because morphine, like furosemide, has got vasodilator effect, which is more in systemic circulation than pulmonary, and therefore morphine can also dramatically relieve pulmonary congestion and respiratory distress. Reduction in respiratory distress would reduce patient's anxiety by reducing the symptom, and plus morphine has got direct anxiolytic action. So the role of morphine is for its vascular effect and anxiolytic action, because reduction in anxiety would again give us the similar benefits of reducing exaggerated sympathetic tone. So morphine also stabilizes the patient of acute aLVF emotionally as well as and therefore hemodynamically. So morphine again is a very important drug to remember in pre-hospital care of acute aLVF for its vascular effect and in addition direct anxiolytic action. Thus we have seen that in management of congestive heart failure, the strategy is reduce workload and help the force of contraction. So force of contraction can be increased by digoxin and dobutamine, which is a selective positive inotropic agent, useful intravenously in management of acute aLVF. Digoxin is relied on in chronic management, but that too a little more cautiously because of its adverse effects, narrow margin of safety, and adverse drug interactions. Next D is dilators, vasodilators, and for chronic management we have AC inhibitors, which apart from vasodilatation are also affecting the or preventing the remodeling. So ACE inhibitors act by dilating blood vessels plus preventing remodeling and also contributing to controlling volume overload by controlling the release of aldosterone. Diuretics in chronic management are thiazide diuretics, and we've just seen why furosemide plays an important role in management of acute aLVF. So these are the drugs for treatment of congestive heart failure. For relieving low output or congestive symptoms, we have selective positive inotropic agents, digoxin in chronic management, dobutamine or dopamine in acute management, acute aLVF. Diuretics, thiazide for chronic management, furosemide in acute aLVF. Vasodilators, AC inhibitors in chronic management, GTN or sodium nitroprusside in acute aLVF. In addition to these drugs in chronic management, we have beta blockers, carvedilol, alpha beta blocker, for protecting from sympathetic overactivity. And in acute management, we have morphine, which has action similar to furosemide, plus direct anxiolytic action, giving symptomatic relief and thereby controlling sympathetic overactivity. And of course, oxygen to take care of the impaired gaseous exchange. So these are the drugs used in management of congestive heart failure in acute situation as well as in chronic situation. I hope this has made understanding of pharmacotherapy of congestive heart failure easy and interesting. So thank you for patiently seeing all 6 videos. Do share this with your friends if you like it, if you feel it was useful. Thank you once again.